Welcome back to the Egg Whisperer Show. I'm Dr. Amy, and today we're diving into a fascinating and impactful area of medicine, interventions that help babies and parents before birth. The title of today's show is Intrauterine Surgery and Other Interventions with Dr. Emery and Dr. Sanfilippo. Our distinguished guests are Dr. Stephen Emery, a maternal fetal medicine specialist at the University of Pittsburgh and director of the Center for Innovative Fetal Intervention. He's on the cutting edge of fetal therapy, including developing devices to treat conditions like hydrocephalus. Dr. Joseph Sanfilippo, a reproductive endocrinologist and former guest on the Egg Whisperer Show at UPMC, past president of the American Society for Reproductive Medicine, and author of an awesome book, Everyday Medical Miracles. You have to get it. Trust me, it is so good if you haven't read it yet. Let's get into a conversation where they'll share their insights, stories of courage, and the exciting innovations transforming fetal and reproductive care. Dr. Emery, you provided a patient story about a woman of uncommon courage whose fetus had severe anemia of unknown cause. Could you tell us about that case and how fetal intervention made a difference?
Sure. Fetal intervention saved that kid's life. This was a woman who came in for her anatomy scan at 20 weeks, routine, and there was a mass in the chest, routine tumor, easy to manage, outcomes are great. But we also noticed a little bit of fluid in the fetal abdomen and the chest, which was unusual. And so we checked for fetal anemia, which is an easy thing to do with ultrasound, looking at blood flow and a vessel in the brain. And that indicated severe fetal anemia. And so we did the workup, and the workup was entirely negative, and the Doppler studies were consistently in the severe range. So we proceeded with sampling the baby's blood in preparation for intrauterine transfusion, which is also a routine thing we do. This fetus was profoundly anemic. A normal hemoglobin for fetus is 15, and this baby was 3. Really profoundly anemic. So we transfused the baby and collected blood and sent that for every kind of test we could imagine. Had the most experienced people at UPMC, hematologists, pediatric hematologists, trying to find out what is wrong. And no one could find a problem. And every time we put blood in a week or so, that blood was gone. And we had to do another transfusion. And I think we did a total of 8 or 10 transfusions just to keep this baby's hemoglobin normal. And we never found out what it was during the pregnancy. And then at around 32 weeks, when we were going in for what we thought would probably be the last intrauterine transfusion, we felt that the baby would probably be better outside the uterus than inside the uterus in these circumstances. We noticed something in the placenta that we had never seen before. And it just sort of took our breath away. It just looked very abnormal. And so we decided to withhold the transfusion and just proceed with delivery, which we did. And the baby did fine, and mom did fine. And then I got a call the next day from the pathologist who told me that there's a mass in the placenta, and that mass is choriocarcinoma,
Wow.
cancer of the placenta, which you never think about in a million years. Now we have a problem. This is a serious cancer. So mom is at risk, and those cells could have passed over to the baby, and the baby could be at risk too. So the plot thickened after delivery. And fortunately, her workup was negative. She did not have cancer. Baby's workup was negative. Baby didn't have cancer. Eventually had the mass in its chest, the tumor in its chest taken care of, which is routine, and problems are solved.
They're routine for you. I got to tell you, when I hear mass in the chest, I feel it in my chest because my heart's jumping out of my body. And I can only imagine how appreciative this patient was that you were her doctor and you were holding her hand through this. Because I think of patients elsewhere where they might not have been given the hope that you gave her. So when a doctor like you says, "Oh, this is routine," I mean, there's just so much comfort that comes with that. So do you think that if she was at another center that she would have received the same care if it was another doctor?
Well, there are a growing number of fetal centers in the United States. McGee's got a lot of experience because we're so big. We have such a large catchment area, and all the moms come to McGee to deliver. But yeah, there are other centers in major cities where she would have gotten similar care.
Yeah. Well, that's such an incredible story. I'm so glad to hear that mom and baby are okay. That's like a one out of a million kind of story,
Yeah.
certainly. Dr. Sanfilippo, let's take a step back. For couples undergoing IVF, can you explain what pre-implantation genetic testing involves and why it's important? And before you do that, I mean, when you hear of a case of a baby, let's say with a mass in their chest, some patients think that PGT and genetic testing of their embryos can actually detect things like that, but it can't. So I'd love to hear you explain more about what PGT is.
Yeah, well, I like to say the advent of this PGT or pre-implantation genetic testing has really changed so many things in a very positive way. So I think the best way to explain this is to step back and to say, okay, when do we do PGT? We do pre-implantation genetic testing under a number of circumstances. We strongly advocated if a woman's over 40. Now, the reason for that, her chances of having a genetic problem, a baby with Down syndrome, and so on, are so much higher than the 25-year-old. So age becomes one. Number two, let's just say there's a family history. In the family history, I don't know, Huntington's chorea or sickle cell anemia, those things come to mind. We have the technology to look at the embryo before we transfer it to the uterus, okay? And you deal with this daily as I do, and it gives us the ability to identify an embryo that potentially will be normal, okay, not have sickle cell anemia, etc. So how is it done? Audience, forgive me if you're familiar with IVF, but in a nutshell, basically, after all the preliminary tests are done, which on average takes maybe a couple, two cycles, then we're ready to roll. And then the way we do this is the patient will give herself self administered injections. We don't want one egg. I always say we want 10, 12 eggs, whatever we can get. So by taking these injections of the actual pituitary gland hormone, we're stimulating the ovary to develop a number of eggs. And we'll monitor that over, again, the course of 12 days plus or minus. What does that mean? Every several days is a blood test, an ultrasound, looking at the follicle development on the ovaries. And then we wind up the cycle. We give the final injection. And then they come to an IVF center 36, 48 hours later. At that point, the patient is in what we call conscious sedation. I like to say twilight anesthesia. And a vaginal probe ultrasound, which again, in your audience, I'm sure is quite familiar, but this time it has a needle that's attached to the probe. From the vagina into the ovary, we take each egg out one by one. And again, patient feels none of this. We then, again, if the plan is IVF, immediately the embryologist fertilizes it with the male partner sperm or occasionally donor sperm. And then I always say, keep our fingers crossed for fertilization and progression. And again, it's a 5-day window. But at 5 days, we went from 2 cells to, on average, around 200 cells. Now, the embryologists, and I always say they're the magicians, okay, as far as I'm concerned. Us egg suckers, I mean, we play a role, but the magic is in the lab. And so what happens there is that then the embryologist takes maybe 5 cells, more or less, something like that, 5, 10 cells from this 200 cells. But I want to emphasize that the location of this biopsy is where the placenta will develop, not the baby. It goes to the lab and then takes about 3 weeks to get the information, and it comes back normal, or our term is euploid, or aneuploid. That's abnormal. Okay, and now we're starting to even transfer aneuploids. Under certain circumstances, these are abnormal as embryos, but they turn out to be normal babies. So that becomes a possibility. And then again, the other indications are in the book that you alluded to, the Everyday Medical Miracles. There's a case of a individual, and the name is anonymous, so to keep it that way, of 5 miscarriages, okay, and then 2 babies that are now normal. And so this pre-implantation genetic testing In that case, were because one of them carried something in their genes. They were fine, but when they go to have a baby, it's miscarriage, miscarriage, miscarriage. And so we can identify this, what we call structural rearrangement, and one more time, identify the non-affected embryo, and that goes in the uterus. And then, like I say, there are other reasons to do the pre-implantation genetic testing, but I think your audience needs to know that the technology has advanced so much and it's made such a positive outcome on, I think it's now 8 million IVF babies that are out there. And so it's exciting. You know, I'm sure you feel the vibration when I get to talk about it. I mean, it really kind of gets me all fired up because it's the ability to deliver this level of technology to our patients that really, years back we just didn't have.
Yeah, I definitely feel the vibration. Vibrate. I was gonna say vibrating is one of my favorite words.
Hmm.
I tell patients to do something every day that
Yeah.
makes them vibrate, to feel alive, because as fertility patients, it's like the life is sucked out of you. So I like that you use that word. I feel it too. So Dr. Emery, tell us about other kinds of interventions you can perform for problems affecting the fetus while it's in utero. What are some examples and why are they important?
Well, here's a great one. This is my favorite. There's a condition where monochorionic twins, so they're identical twins, they share a single placenta. And then there are blood vessels that connect the two. And so normally there's the same amount of blood that's going from one twin to the other, and there's equilibrium and they get along fine. But about 10% of the time, there's more blood flowing towards one twin than there is coming back. And that sets up the condition called twin-twin transfusion syndrome. And if it's severe disease early, which it usually is, then the natural history is that you'll lose both of them. Okay. But what we can do now is we could take a 3 millimeter scope, like the scope the size of the inside of a ballpoint pen, and we can go inside the sac of one of the twins and we can find those blood vessels on the surface of the placenta and cauterize them with a laser fiber and effectively separate to circulation. So now it's as if the fetuses have their own placenta. And so the disease regresses, the sickness in each of the twins corrects, and they can go to near term. And now the reason I love this best is, in my opinion, this intervention has the best risk benefit assessment in all of medicine because the outcome is intact twin survival. Think about that, intact twin survival done under IV sedation and local anesthetic. It's
Wow.
amazing.
Wow.
Yeah.
Well,
Yeah. And then how long has that technology been available?
That technology really started becoming mainstream in the late 1990s, early 2000s.
That's incredible. Dr. Sanfilippo, the question I have for you is how should women prepare if they're planning to get pregnant? Are there guidelines or best practices they should follow before conception? I get this question all the time, and I'd love to hear what you tell your patients who ask you.
absolutely. And I put this in the category of preconception counseling, and it's a very important concept. So let's just say a woman, a couple say, hey, I want to get pregnant in 6 months or 1 year, and that's what I hear. So there is a lot of good ways to prepare to make that as ideal as possible. And including your audience, you can go online to what it's called the American College of Obstetricians and Gynecologists or American Society for Reproductive Medicine, and they have a lot of information for individuals. But the key points are something like this. Number one, lifestyle. Let's clean things up. Smoking, alcohol, negative. Okay. And again, how much alcohol should you take when you're pregnant? Zero. Okay. These kind of things. Smoking can have an adverse effect on the fetal development, etc. The next category is medical problems. Okay, so let's say you have a thyroid condition, thyroid problem. Let's get that in tip top shape. Diabetes comes to mind. And if you're a diabetic, you automatically know about hemoglobin A1C. And again, here I defer to my maternal fetal medicine colleagues, such as Dr. Emery, to say, get that hemoglobin A1C 6 or less. That's what they tell me. So let's take care of medical problems. Vaccination. Are you up to date? Because you want to get that done before you get pregnant. And then another good thing is called a carrier screening. So it'd be a good idea for you, the patient, if it's not already offered to you, to say, hey, can I be tested to see if I carry the gene like for cystic fibrosis? You would have no clue. And so if you're a carrier, then your partner also has to be tested. If you're a carrier and your partner's negative, story ended. If you're a carrier and he's a carrier, you have a problem. And that's where your other question of pre-implantation genetic testing can come in and identify that child that would develop cystic fibrosis. So the other thing is prenatal vitamins. I always say to a patient, I want you to get pregnant when you have good levels of folic acid. What are we talking about? Being on prenatal vitamins, folic acid for several months before you even attempt a pregnancy. It's clear that folic acid and spinal development are correlated. Okay. And again, Dr. Emery is a far better authority than I am when it comes to those kind of things. All right. But, if you get all your ducks in a row, you're ahead of the curve. Now, a couple other things is I always say, let's say you're attempting a pregnancy, and depends on how old you are. If you're less than 35, theoretically, you can spend up to a year attempting a pregnancy. If you're 35 to 40, we shorten that to 6 months. If you're 40 and you say, I want to get pregnant, you need to get to the doctor today. Okay, not tomorrow, but today, because the sooner the better. So once you start trying to get pregnant, and I always like to say, if you see you can't get pregnant, say something, okay? Speak up. The sooner you get to your OBGYN or an infertility specialist, you're ahead of the curve, because there's so many things that we can do to make that pregnancy happen or make it as ideal as possible. We don't promise you anything. You can't do that in medicine, but we can set the stage for success.
Right. No, those are such great tips, such great tips. And then some of our patients end up seeing a maternal fetal medicine doctor. And so many of my patients, they don't even know what that subspecialty is. Dr. Emery, can you tell us what exactly does a maternal fetal medicine doctor do? And when are you involved in a pregnancy?
So fortunately, most pregnancies are normal. It's great. But sometimes they're complicated. And they're complicated because, for instance, mom has some kind of condition. She's got lupus, or she's got diabetes, or she has heart condition, in which case the chances of a complication during the pregnancy increases significantly. So there's a role for maternal fetal medicine in managing those types of patients. And then there are patients where there are fetal anomalies that require extra level of expertise in managing the pregnancy and when to deliver, where to deliver, how to deliver, who to have on hand. And then, the fetus is complicated by either fetal or maternal infections, genetic syndromes, et cetera. Anything that's out of the ordinary that a general OBGYN would be comfortable doing, that's where MFM comes in.
So many IVF patients ask me, so now that I did IVF, I guess I'm going to be high risk now and I have to see an MFM doctor. What do you think about that?
No, I don't think that's true. If you're pregnant and you're normal, stay with your OBGYN,
Yeah.
because you already have that relationship and you don't need to see an MFM, because there are enough people that really need to see MFM that really should be seen by that group of people. So it's a much smaller pool of providers. So you want to keep things equal.
Yeah. And you're developing an in-utero shunt device to treat fetal hydrocephalus. Can you explain what that is, how the shunt works, and what it could mean for affected families?
It's a very interesting story. So back in the 1980s, and the birth of fetal medicine, right? We had this new technology called ultrasound. And we could, for the first time, we could look inside the uterus and see what's going on. And one of the first targets for in utero intervention was fetal hydrocephalus, because it seemed like it was an obvious diagnosis, because fluid shows up as black on ultrasound. So You put the ultrasound probe down and you see black inside the skull, the fetal skull, then that baby has hydrocephalus. So people started putting shunts in, thinking that they could drain the excess fluid and get better outcomes. And after a couple of years of doing that, there was an international registry that looked at the results and found that shunting did not help and actually may have harmed. So there was a moratorium placed on shunting back in 1986. And since that time, there has been essentially no progress in this diagnosis. The way we manage them is we just watch on ultrasound, we get them to term, we deliver them, and then we manage the neurologic consequences. Back in 2014, I had a patient whose fetus had hydrocephalus. And let me just back up and say what we're talking about. So cerebral spinal fluid is made in the lateral ventricles, okay? And then it travels centrally to the third ventricle and then out the brain through the aqueduct of Sylvius to the fourth ventricle, and then it circulates and bathes the brain and spinal cord. With aqueductal stenosis, that duct is obstructed. So cerebral spinal fluid continues to be made, but it's got nowhere to go. And so it just compresses the brain against the skull, and it kills those brain cells. And it fundamentally disrupts the way the brain develops. So they have really, really significant neurologic outcomes that are going to be lifelong, right? And that's why it was a target back in the 80s, because the outcomes were so bad. So I had this patient in 2014, and I thought, you know what, this just can't be right. So I pulled that original paper to the registry, and I read it, and there was the answer in black and white. Back in 1980s, you couldn't make the diagnosis of aqueductal stenosis. The ultrasound just wasn't good. But you compare how the world has changed. Just think for a second how the world has changed since the Apple Macintosh was the coolest technology on the planet and Ronald Reagan was president of the United States. It's a different world, especially in medicine. We have high-resolution ultrasound. We have MRI that didn't exist back then. We have next-generation genetic testing. We have all these tools. And so I proposed to the International Fetal Medicine and Surgery Society, which was the organization that put the moratorium on the shunt. I said, it's time for an evidence-based reassessment of this. And they said, yeah. And so I've been working on that since. I developed a shunt with the help of a bioengineer. I told him the necessary performance characteristics. First and foremost, it has to be placed with ultrasound guidance, percutaneous with ultrasound guidance. So no incisions in the maternal abdomen, no incisions in the uterus, nothing like that, because maternal well-being is paramount. So we developed a shunt. We developed an animal model to test it in the pregnant sheep. We achieved proof of concept about a year and a half ago. We got a $2.3 million NIH grant. It's called an incubator grant, which the NIH provides both money but also expertise, the people that you need to do the engineering, validation, verification testing, the biocompatibility testing, all that sort of stuff that has to be done for a medical device to go before the FDA. So we are in the process of developing our FDA application. After we have FDA approval, there will be the first in-human trial, and then hopefully, before I retire, this will be a thing. And what we anticipate is that when we put the shunt in around 24 weeks gestation, it'll take the pressure off the developing brain. The brain will be allowed to repair from the damage that's been caused so far, and then also hopefully assume a more normal developmental trajectory.
Oh, that's incredible.
So that these kids will be born basically normal,
Yeah.
normal lives.
Wow. Oh, that is so cool. That is so cool. Dr. Sanfilippo, I learned that one of your research interests includes a trial for fibroid prevention. And fibroids are so common. And so I know a lot of people want to learn more about that. Tell us more about it and what's the study focused on, who it might help, and why it's important.
Let me give an example of a patient that I like to say showed up in my office or on my doorstep one day, and she was 16. And she was referred by the cancer doctors, the oncologists, and they had done a biopsy. And the biopsy, good news was it was benign and it was a fibroid. So here she is, 16 years of age. One of the problems is that the fibroids were so large. And when I say large, they were basically up to her sternum, all right? And unfortunately, for instance, in the middle of the night, she would have to get up many times because these fibroids compress the bladder and, the capacity was limited and so on. Fast forward, we operated on her, removed the fibroids, uterus was very normal, and stayed normal for a while. Unfortunately, which is common with fibroids, they regrew. So she's been maintained on some medication to control the growth. The medicine works as long as you take it. In other words, you could never take this and get pregnant. That wouldn't work. Now she's graduated actually from pharmacy school or whatever. And where I'm going with this is her outlook to carry a pregnancy is reasonable, okay? But fibroids are notorious for the fact that they can give you heavy vaginal bleeding. They can give you pelvic pressure. Certainly, as I allude to, getting up in the middle of the night because of the pressure problems. And with your permission, I got a little model here. If I could hold that up, okay? And this is a fibroid that's in the lining of the uterus. Worst place to have a fibroid. This is going to equate with a lot of bleeding. Fibroids toward the outside or in the muscle are less of a concern. Still a concern, but less of a concern. So location is the key thing. Now, let's just say this same person has fibroids and heavy bleeding, and she would like to get pregnant. Okay, now, number one, it's common to have miscarriages because it just is common sense. If your fibroid is in the lining of the uterus, is going to affect implantation and so on. So we can treat that by operating in the uterus. Okay, so we're going to call that hysteroscopy, where we shave down the portion of the fibroid that's in the cavity, and that seems to work. The lining of the uterus theoretically would grow over, so on. We don't have to take it out. If that doesn't work or there's other concerns, we can take these fibroids out. We can do that through a belly button incision, laparoscopy, frequently accompanied by a small incision. We call that a mini laparotomy because once the fibroids are out, we want to put that uterus back together as perfectly as we can. It's got to carry a pregnancy. Now, if you have a so-called myomectomy, which is, as you know, our name for removing the fibroids, you do run a risk of rupture during pregnancy. Very, very, very rare. And I don't want to scare your audience, but to just say, if you get pregnant, there's always a small chance of that thing. But we can address these fibroids. Now, research-wise, what we've been doing is looking at the genetics, okay? If we can understand the genetics in this day and age, maybe we can alter that somehow, okay? I mean, there's a number of what we call checkpoint aspects, et cetera, of the genetics. I won't go into the details, but just to say, for us, the researchers, let's get a handle on the genetics and then see if we can, in a positive way, affect that, okay? And then allow that patient to proceed with, again, either a term pregnancy or pretty close. What causes fibroids, again, is unknown. There's very loose questions about diet effects, red meat, it's not black and white, but gray. If you're on birth control pills early on, that can have an effect, etc. Birth control pills per se can make fibroids grow because of the estrogen in the pills. Just to summarize and suffice to say, the good news is they're benign. It's very rare that they turn out to be what we call a sarcoma, okay? But that's always a small possibility. So if you notice heavy bleeding, pelvic pressure, if for some reason I have to urinate more frequently at night, speak up. That's the term to get an ultrasound and make the diagnosis.
Well, that's very exciting that maybe one day there could be even a cure for
Mhm.
fibroids.
Sure.
Yeah. So, this question's for both of you. For listeners who might find all this medical science overwhelming, what's the key takeaway about how these advances give more options and hope to patients and families?
I'll start. Like Dr. Sanfilippo, there are a lot of really brilliant, hardworking, dedicated people in the field of medicine who are trying to make things better for patients. And so over time, it just always gets better. And that's always something to keep in mind for your patients. And if your patients have questions, have them ask their doctor, their OBGYN. A lot of people of this generation get a lot of their medical advice from social media, which may not be the best place because for obvious reasons. Just trust your doctor and keep the faith that medicine just continues to get better.
Have and continue to feel very strongly that patients need to be informed, and we need other vehicles other than internet. And that was why I put together that book, Expert Guide to Fertility, which was designed and is designed and continues to be a companion for anyone going through infertility. If you have endometriosis or you can't get pregnant or you need to get a surrogate carrier or you don't know how to finance the infertility. So Expert Guide to Fertility boosts your chances for pregnancy is one thing. And the other thing is, as you started our discussion in the podcast, the Everyday Medical Miracles is designed to share our life as healthcare providers and our most interesting and challenging patients. Okay, what was it like? What's it like to deliver a baby in the front seat of a car? That kind of thing, and that's included in Everyday Medical Miracles. But the most important advice, and I echo what Dr. Emery said, but I'm going to do a little tweak on it. If you're trying to get pregnant and it doesn't happen, speak up. The sooner you speak up, the better. There's so much we can do to help you, and every doctor is attuned, every OBGYN, to infertility, and every infertility specialist is attuned to help you and deliver kind of what's state of the art.
Yeah, great answer. Finally, if each of you could point to one breakthrough that will most affect fertility and fetal medicine in the next decade, what would it be and why?
Okay, I'll start. AI is going to change the face of the embryology laboratory, and it already is. Artificial intelligence is going to allow you to come into a doctor's office and have the history put together. The doctor's going to have that readily available, so we've saved that time. We can focus on exam and advice. And so to me, that's one of the most important advents, if you will.
Great. I just bought the website dramy.ai yesterday. So
There we
it
go.
looked like I timed that well.
What I tell medical students who rotate through with me that when I was at their stage in their career, the field that I am in didn't exist. Okay.
Wow.
So medicine evolves and it grows and it gets smarter. And it, like Joe says, with AI, it's going to get even better. So we're really excited. I think there are going to be a lot of breakthroughs with gene therapy for fetuses that have a genetic condition. We can actually go in and repair that genetic defect in the fetal stage to prevent that disease from ever happening. That's on the horizon. That's going to happen.
How many years? What do you predict?
5.
Wow. Oh, that's so incredible. That's
Yeah.
incredible.
So
Yeah.
it always gets better.
Yeah. So if people would like to find you and your work, this is questions for both of you, where can they find you?
People don't have a problem finding me. I don't really have a social network presence. That's intentional. My email address, emerysp@upmc.edu, is public. So that's probably the best way to get hold of me.
Great.
I would say twofold. One is with the Everyday Medical Miracles, we put together a website, and you can easily contact us at www.everydaymedicalmiracles.com. And similar to what Dr. Emery mentioned, mine is sanfjs@upmc.edu. And we would be happy to help in any way we can.
Aw. Thank you for joining me today. I feel like I'm among some of the greatest minds in medicine, and I just feel so lucky that you guys took time to talk to me today so that people who follow and listen to my show can just hear from you about some of the incredible things that you are doing to make things better for women and babies. So thank you so much. Dr. Emery and Dr. Sanfilippo, thank you both for joining and sharing your expertise and the hope these interventions offer families. Special note, Dr. Sanfilippo's books, Everyday Miracles, an expert guide to fertility. They're both available on Amazon and Barnes & Noble. For Everyday Miracles, he and Dr. Andrew Jaja joined me to talk about this book, and we also talked about the expert guide as well. I'll be sure to drop the links in the show notes if you missed them. Thank you all for tuning in. Don't forget to subscribe to the Egg Whisperer Show on YouTube and follow us on Apple Podcasts or Spotify so you don't miss an episode. See you next time.